So welcome back to part 3 of this Langford Academy session on Addison's disease. And in this session, we're going to be talking about the chronic management. So when we talk about chronic management of Addison's disease, quite a lot's changed in the last few years. Fludrocortisone used to be widely available and was therefore really commonly used. And since its discontinuation, we've transitioned to longer acting forms of mineralocorticoids. So DOCP, so desoxycortisone pivalate, is ultimately a drug that's been used to manage Addison's disease in dogs in the States for decades. And it was originally licensed under the trade name Percortin in 1998. And the dose was 1 mg per pound, which directly converts, there's 2.2 pounds in a kilo, to our recommended starting dose of 2.2 mg per kg. And the recommendation is to give it on a 25-day basis. And we've got a lot of literature from the States on this drug because they've been using it for decades. And dosing the drug at this dose, but also considering the drug as a long-term option, the vast majority of patients report an excellent clinical outcome with use of this drug. However, there are a number of studies and various literature that essentially demonstrates that the overwhelming majority of dogs can tolerate a significantly lower dose than this, and more than tolerate it, actually. We can see complications at such a high dose in terms of either hypertension or seeing excessive mineralocorticoid action, obviously of which one of the possible signs is hypertension. And so therefore, and actually primarily driven by price in the States, because it's a really expensive drug, and ultimately it's given lifelong, and therefore if you can reduce the dose of your drug on a monthly basis, you can reduce the cost to the owner, and that can make managing the disease longer term much more affordable. So in the States, various studies were done and demonstrated that around about a 50 to 60% reduction in dose can be achieved in most dogs with a great clinical outcome. So they hit all their targets in terms of their electrolyte values, but also they're not getting complications such as hypertension. And so the recommendation is certainly to dose at substantially lower doses than the starting dose based on the available literature. Percortin's given intramuscularly, and more recently we've had a subcutaneous version of DOCP licensed in the UK called Zycortal, which I'm sure over the last sort of 5 years or so you've all become really familiar with. So really then we should be dosing DOCP on an individualised basis, and there's plenty of literature to demonstrate that a starting dose of 1.5 milligram per kilogram is sufficient for most dogs. Indeed, half of the recommended dose, so even 1.1 milligram per kilogram versus the recommended 2.2 milligram per kilogram, even that low dose is safe and effective for most dogs. And even if either the 1.1 or the 1.5 is not adequate for that patient longer term, because they are one of the minority who needs a much higher dose in the longer term, they're still safe and effective doses to manage them and prevent them being or developing hyperkalemia of a concerning level. So it's still absolutely fine to start at these lower doses. There's some evidence to suggest that the younger dogs are at diagnosis, the higher doses they may need, although this is typically still less than the recommended dose of 2.2 milligram per kilogram. And so we're in a position where the sort of licensing recommendations do vary somewhat from what the literature tells us, and also what most specialists would recommend. So most specialists will recommend a starting dose of DOCP of around 1.5 milligram per kilogram, there or thereabouts. And this also, as well as being sort of clinically probably more optimal, also is cheaper for clients based on sort of the cost of the drug as well. So when we're dosing DOCP, really what we want to aim for, based on the information we've discussed before, is achieving individualised therapy with our mineralocorticoid replacement. So ideally what we want to be achieving is a sodium-potassium ratio of 28 to 32 throughout the dosing interval. The way we achieve that is by evaluating what the peak action of the DOCP is by measuring our electrolytes at day 10. And then we want to know what the duration of action is by measuring our electrolytes at the anticipated extent of the DOCP action, which is around about day 25. So a couple of elements on practicalities before we talk about the sort of detail here. So one is to say I start DOCP when patients are bright, happy, eating and ready to transition to oral prednisolone therapy for the glucocorticoid part of their replacement. I will transition them to DOCP at the same time. I think the other practicality to mention here is the 25-day interval, and the fact that that is just really tricky for owners to remember. But also sometimes if we strictly follow a 25-day interval, sometimes that will fall at the weekends or when the usual veterinary clinic is not open. And therefore, I think it's often much easier for owners to pitch for a 28-day interval. And again, we're going to be saying to these clients, much the same as we're going to have to be saying regarding the dose, this recommended dose or this recommended interval is off license, but this is what's recommended based on available knowledge, literature, specialist opinion, etc. So in terms of our day 10 blood sample, basically, if our day 10 blood sample has a sodium potassium ratio of between 28 and 32, that means we've hit the sweet spot with our initial dose of DOCP in this patient. And next time they're due a dose of DOCP, approximately 28 days, we will give them their starting dose again, because that dose is ideal dose for them based on the peak action of the drug determined by the electrolytes. If at day 10 we've got a sodium potassium ratio less than 28, the dose was inadequate for the patient, they're trending back towards Addisonian at this stage. Whereas if at day 10 the sodium potassium ratio is more than 32, that suggests we've overdone it with the mineralocorticoids, and therefore when a dose is due at the end of the interval, that patient would need less next time around. So we use our day 10 electrolytes to inform what dose we're going to give next time a dose is due. And we would go through that process after every dose change. And I think it's fair to be realistic with owners. It's not uncommon to need sort of 4, 5, 6 plus dose changes in some of these dogs to hit the correct dose. In terms of the interval, again, we're aiming for that sweet spot of 28 to 32. And if we've got a sodium potassium ratio in that interval at day 28, that is probably a perfect duration of action for that dog. Whereas if the sodium potassium ratio at day 28 is less than 28, that suggests the DOCP stopped working sometime prior to that. So I would give that dog its DOCP then, but bear in mind next time round I want to measure my dosing interval electrolytes around about the 3-week mark to see at what stage the DOCP is losing its activity in that patient and how short I need to pull my interval. Whereas if at day 28 I've got a ratio of more than 32, that suggests the DOCP is still having a significant action in that patient, and I'd remeasure my electrolytes on a 3 to 7 day interval to identify when the sodium potassium ratio falls into the range of 28 to 32, and then I'd consider that patient appropriate for redosing, and that would identify that patient's dosing interval. So there's quite a lot of tinkering. It's relatively straightforward, and I think the literature available around how to dose these patients is really helpful. I think the thing that's challenging is the huge individual variability in this drug, in so much as intervals of anywhere from 14 to 90 plus days are described. So that's the range of individuality we're dealing with here. And doses from as little as 0.37 to 2.5 milligram per kilogram are described. So it's really, really difficult to identify in an individual patient where you need to be unless you're doing this really close monitoring. So as well as mineralocorticoid replacement, all patients who've had an Addisonian crisis are essentially a glucocorticoid replacement as well. That's been demonstrated by your ACTH stimulation test with a flatline cortisol. And prednisolone we would start at 0.5 to 1 milligram per kilogram per day. And then ultimately I'm aiming for a lowest effective dose. And I think the main thing to be aware of here is that many Addisonian patients need a really, really, really low dose. So as little as 0.05 to 0.1 milligram per kilogram per day. There's no blood test we can do to monitor Prednisolone replacement, we're monitoring clinical signs. And I think some of the biggest challenges we see are ongoing PUPD and ongoing lethargy, which are usually due to excessive steroid dosing. And then at any time when we're anticipating stress, so either sort of kennels, other illness, we should double the dose from the dog's baseline for that period of time, so that we are providing adequate cortisol replacement for stressful times. So I guess just as an example as to what we see, so Billy we've used as our example throughout. I started him on a fairly low dose, 1.2 milligram per kilogram. That was due to my perceived sensitivity of his response to the hydrocortisone. And then ultimately over time, we've gradually tapered him down, and he's currently on a dose of 0.78 mg per kg with an interval of around about sort of 37 days. So substantially over the dosing interval and under the recommended dose. So this is where individualized dosing is so important. And then prednisolone, just 1 milligram, which for him at his body weight is approximately 0.05 mg per kg per day, which I think is fairly common in many of these patients. And just a final word about atypical Addisonians. So this presentation has been discussing the typical Addisonian, so where they've got combined glucocorticoid and mineralocorticoid deficiency, which is by far and away the majority of patients. And that is typified by patients who present with both mineralocorticoid deficient signs and glucocorticoid deficient signs, as we outlined in the earlier stages of this discussion. Isolated cortisol deficiency occurs, and it occurs probably in about 30% of our Addisonian patients on presentation. And so this is where they've just got sort of lethargy, inappetence, malabsorptive disease, gastrointestinal signs, and you'll just see the cortisol deficiency abnormalities on their blood screening. So as we said, lack of a stress leukogram, maybe an anemia, hypocholesterolemia, hypoalbuminemia, less commonly hypoglycemia. And so anytime we've got any of that constellation of clinical signs, it is worth considering Addison's and doing an ACTH stimulation test to diagnose them. This subset of patients only requires glucocorticoid supplementation. So if they've got no electrolyte derangements, then we just manage them with glucocorticoid supplementation. The doses are comparable to those I've described for Billy or in standard chronic replacement. A proportion, and this is probably fairly poorly defined as to what proportion of patients go on to develop typical Addison's, but a proportion of these will develop mineralocorticoid deficiency at some point in the future, classically within the first year post-diagnosis, if that's going to happen. It's really, really difficult to predict that, and some clinicians recommend monitoring sort of electrolytes on a relatively frequent basis to try and identify that. I just think the likelihood of you picking up when that's going to be is actually really low. And so I generally tend to take the approach where I say to my clients, developing typical Addison's and an Addisonian crisis is a risk. If your dog is ever poorly, even if it's mild inappetence or lethargy, just take them to the vets for their electrolytes, because I think that's a much more targeted way and a better use of money in terms of identifying that possible crisis and treating it appropriately if it happens. So prognosis is excellent for both forms of Addison's disease with appropriate care and monitoring. I think the main barrier for owners is the cost, particularly of the drugs, but also the ongoing monitoring as well. So getting drug therapy individualised to minimise overdose and sort of excessive cost associated with that is really helpful. And then we will also see reduced adverse events with individualised therapy, so less risk of complications such as hypertension or other concerns as well. So thank you so much for joining me for this presentation or series of presentations on Addison's disease. I really hope it was helpful to you, and we'll see you soon.